Hi, my name is Jo Gibson and I'm a clinical physiotherapy specialist working at the Liverpool Upper Limb Unit in Liverpool in the UK. And I also work as a consultant in private practice. I'm really chuffed to be here again on a Monday evening to talk to you about all things shoulder related. If you've joined us over the last few weeks, you know that we've been talking about some interesting case studies, and I fully intend to return to that. But I thought tonight it would be nice to talk something a little bit more rehab related and talk about an interesting patient I've had in clinic and use that really as an excuse to have a look at the current evidence and see if things have changed. So the lady I want to talk to you about tonight is an 82-year-old. She's a retired radiologist. Really lovely lady, and she has basically had a little bit of a fall, had some shoulder pain, hasn't got better. She's had symptoms for nearly a year, went to see her GP, who sent her straight to an orthopedic surgeon because she had private healthcare. And essentially, he then said, well, your x-ray's fine, there's no arthritis, did an ultrasound scan, and essentially told her that she had a massive rotator cuff tear involving supraspinatus and infraspinatus. And essentially, he wasn't keen to operate and he wanted to try conservative measures first. Now, in the year that had transpired, she'd had cancer, she'd been diagnosed with Parkinson's, and she'd had a pretty horrible time. And so it had become very clear that she wasn't a good surgical candidate anyway, and she certainly wasn't at stage she was going to consider having any surgery done because of the other health issues that she had. It's great to see so many of you joining us. Thanks, guys. I promise I'll answer all the questions at the end as ever. So thank you. Great to see some familiar names joining us. So back to my lady. So essentially, she's pretty fit and healthy for an 82-year-old, very independent, lives on her own. During COVID, because she couldn't get out walking, she hired a treadmill so she could still do her walking at home, because she didn't want to be out and about, because obviously she was in an age group that was at risk. So I was on a bit of a winner here, I thought. But I guess really, when I look at this lady, she had really poor range of movement. She could literally had that very typical shrugging, hitching of the shoulder when she tried to lift her arm up. Passively, she had full range and no rotation restriction. And as I say, there was no sign of arthritis on an x-ray. But when she tried to actively move her arm, flexion, she had 30 or 40 degrees, abduction about 10 degrees, and both were very, very painful. If she tried to actively abduct, it was also, actively external rotate or even externally rotate, she was also very painful. She couldn't lie on the shoulder at night. The other shoulder was fine. As I say, pretty independent, doesn't do any particular sport, just likes lunching and seeing her friends, which obviously is a bit curtailed at the moment as well, but a very switched on lady and coping very well despite the fact she's had a pretty horrid time. So what are my options with this lady? Well, one, I know that she's got a massive rotator cuff tear. And I guess the first question is, what do we mean by a massive rotator cuff tear? And if you look at current definitions, essentially we're looking at somebody that has a tear that is retracted to the glenoid rim or 5 centimeters in one tendon, or 2 or more of the rotator cuff tendons involved. Now, when we look at the issues and we look at the research, looking at this group of patients and things that we might want to consider in our exercise prescription and where I might want to start, then there has been some quite interesting research that might give us some options to do things a little bit differently. But of course, I'll talk to you about what's out there in terms of our rehab options at the moment. But if we look at the kind of research about what are the common issues in patients with painful massive rotator cuff tears, then essentially, well, one, we know they've lost that normal force couple that kind of keeps that humeral head relatively centered in the glenoid, and that loss of force couple clearly potentially results in that superior migration of the humeral head. And so there's a lot of focus on perhaps trying to address that. Now, the other thing is Gumina et al. Did a study looking at tears and association with proprioceptive deficits, and again showed that there was a clear link between rotator cuff tears and proprioceptive deficits, mainly in terms of joint position sense and kinesthesia, and the extent of these deficits directly correlated to the size of the tear. Now, the other thing, some very interesting research done by Veronica Comboy, who's a surgeon down in Torbay in the UK, actually looked at fMRI and actually scanning the brains of people with massive, again, irreparable rotator cuff tears. And what she found that there was actually evidence of degeneration in the grey matter in the brain in the areas specifically concerned with proprioception, but also with reach and grasp. So, and interestingly, the degree of degeneration directly correlated with the degree of impairment that patients presented with. Now, we see other studies showing that patients with significant hitching, very poor scapular dyskinesis, again, if that was addressed, that seemed to correlate with some change in symptoms. And there's no doubt when we look at the patients that do well, it seems to be if we can influence their strength in flexion and abduction, and no great surprise, improve their range of movement, then that correlates with better functional outcomes. So we know what defines a massive rotator cuff tear. We know what some of the issues are in terms of looking at the specific dysfunctions and deficits. But what's out there in terms of rehabilitation options? Well, I think it's fair to say that a lot of emphasis has been placed on what's referred to as the anterior deltoid program, where essentially patients start lying in supine and essentially find a way that they can assist the arm into 90 degrees of elevation. So it might be assisting it with the other arm to start with, just short to long lever up to 90 degrees. When they get confident and can do that independently, then they start to move small circles or small range of movement between about 70 and 120 degrees of elevation. When they get confident at that, they add a load in. And when they get confident at that and can cope with a load, then we start to work them against gravity by glitching up or changing the inclination of the bed. So we get them to work and then ultimately progress to things like a wall slide. Now, the anterior deltoid program actually gets a lot of criticism because what authors would say is that essentially if you work anterior deltoid and really bias it, then the risk is actually you're promoting, if you like, that torsional force on the humeral head and potentially making it worse. However, the key thing that probably relates to why the anterior deltoid program has been shown to be successful in some patients is that essentially if you think what I just said, patients start in that supine position at 90 degrees of elevation, and anywhere between 70 and 120 degrees of elevation, actually that's where deltoid has a real stabilizing role on the humeral head. So actually the deltoid program directly addresses that, and certainly Anne Kuhl's work looking at EMG, and again we have to be honest about some of the limitations of EMG research, but her research would suggest that it doesn't just work anterior deltoid, it also works the other parts of deltoid as well. Now, in terms of success of the anterior deltoid program, as it was described by Bobby Ainsworth many years ago, 2006, I think was her first paper, she looked at that very simple progression, but she also looked at targeting the remnants of the cuff. So she advocated doing isolated external and internal rotation supported alongside that progression that I've just described, and reported success in a small number of patients. Now, Ophir Levy did exactly the same with 17 patients. So again, not a big series of patients, but interestingly, his cohort directly related to the lady I've told you about, in that they were all patients over the age of 80, in fact, up to their mid-90s. Now, what was interesting in Ophir's study is that many of the patients, like this lady, had significant restriction of range of movement, so only 30 to 40 degrees of elevation before they started, so real pseudo paralysis. Now, in his study, actually 80% of patients did very well and achieved 160 degrees of elevation. But the important thing from this study, it took them up to 9 months to achieve that. So it did seem to take a long period of time. Now, interestingly, another author much more recently, Christiansen et al., again looked at using this deltoid program and did a very simple 2-exercise approach. So they did that deltoid progression, or if you like, that flexion progression from supine up to the vertical position as they were able with increasing load. And they also did external rotation. Now, again, the reason for this is if we look at studies that look at patients with massive rotator cuff tears with pain, and we look at patients who have massive rotator cuff tears and don't have pain and have good function, the ones who have less pain and good function seem to use the remnants of the rotator cuff, particularly subscapularis and teres minor, at a higher level than those patients with pain. And importantly, they also seem to use all their scapular muscles rather than just compensating with upper fibers of trapezius with that very typical shrug. Now, when we start to drill down to the detail in some of these studies, it's actually really interesting because Offerlevy's study, as I say, showed that in a significant number of his population, they did very well in terms of their range of movement and their strength in flexion and abduction. But interestingly, there was no increase in terms of external rotation, strength, or range of movement. Christiansen found exactly the same in that there was a consistent improvement in pain and strength in terms of flexion and abduction, but again, no real change in external rotation. But patients did get a significant improvement in their quality of life. Now, in Christensen's study, it only took 5 months. Now, this was a younger cohort of patients, so the average age in this study was 70 rather than 80. And the other thing that was interesting is they did some EMG with the theory that if they looked at EMG before and after the intervention, they'd see an improvement in deltoid function and a reduction of upper fibers of trapezius. I think it's fair to say that what they actually saw was a huge heterogeneity of different compensations after the rehabilitation intervention. Now, think back to what I said. So the anterior deltoid program seems to have a good prognosis in some patients. So what we need to revisit when I've just talked to you about some other approaches is what are the prognostic factors? How do I know if this lady is somebody who's likely to do well or whether I maybe need to sit down and have a discussion about her expectations? Well, there's some other really lovely research. Remember what I said in terms of what the research tends to identify as some of the key issues in this patient group. We know they've lost that force couple because they've lost that balance between the cuff and deltoid. We know that they've got some proprioceptive deficits. We know there's some changes cortically. And we also know that scapular dyskinesis in this group, if we change it, seems to have some relevance. But clearly, the deltoid program with a bit of external rotation isn't necessarily targeting that. The good news is somebody's looked at that for us. So there's a couple of authors, Collins and Agut, and also longer term results presented by Cavalier et al. And I'll post some links to those papers because they're definitely worth a read. But essentially, they looked at a program that really encompassed many of the things that we've talked about. So essentially what they did is they looked at really they did some soft tissue work initially just to release off some of the compensations these patients had, mainly around upper trapezius and levator scapulae. But then in terms of their exercise intervention, they really put some emphasis in terms of a much more normal movement approach, if you like, to rehabilitation, in that, again, they did the supported mobilization, but they did it in sitting. So again, they were sitting next to a table, so they were working in that 90-degree plane, that between 70 and 120, where, remember, deltoid really has its stability function. But again, they did things that they started with 2 arms, they went to 1 arm, they really targeted function and vision. So think of those cortical changes. So as they got them doing table slides and things like that, they got them reaching to a specific target and then progressed it through from there. Now, the other thing they did was they did some passive correction of the humeral head. Now, I'm not advocating that. I'm just going to talk to you about the things that were successful in this trial and then talk to you about perhaps how I think we can apply it. They looked at some very specific scapular exercises that targeted upper serratus. So if you like, again, doing protraction higher in range and again at this 90-degree position. So if you're just doing a table slide, you can achieve a whole lot of things that tick many of the things that we said that were an issue. We can target proprioception by having a target that they work towards. We could get a ball underneath them to give them a little bit of feedback as they're rolling. We could work across midline, again, to really target those cortical changes. But really what these authors described was really trying to target more automatic movement. So if you like, trying to improve that cortical representation as well as looking at getting that muscle system to actually compensate. But they probably put more emphasis on looking at the scapular muscles specifically. Now, interestingly, the groups that were included in these studies were a little bit younger, so they were more kind of late 60s, early 70s. Again, there was a consistent effect in terms of improving abduction and flexion. Again, there was not a predictable increase in external rotation, something we don't seem to be doing as well. And interestingly, the increases in range in this study perhaps weren't as dramatic, but when you saw where the patients started, they didn't have such major deficits as described in the Leffy and in the Leffy study. So in the Agut study, they started with about 112 and they got up to 140. Similarly, very similar results in the Cavalier and the Collins study. But again, what does this tell us? Well, one, it tells us there's lots of different things that seem to work. So the good news is we should be able to find something for our patients. And I think for me, when I look at my kind of my practice and how it's evolved with these patient groups, I think I was very kind of influenced by the fact that I had patients in their 80s with massive cuff tears. Surgery was never going to be an option, and they couldn't lie supine. So at that time, it was kind of, well, I can't do the anterior deltoid program if they can't lie in supine because I can't do that progression. So how can I apply those similar things in terms of my practice? So for me, what I like is, okay, we've got some evidence that suggests there's some successful approaches, but what is the thing that helps us identify the patients that are likely to do well? Well, certainly Bobby Ainsworth, when she first published her research, was very key that if you could find somewhere that patients could almost achieve some form of elevation, then that seemed to be a good prognostic indicator. So, for example, if in supine, they could do short lever with minimal assistance, or if they could side lie, like with an ironing board or a table next to them, and again, they could achieve elevation. If you could find some way of supporting the limb to achieve that elevation range to 90, that seemed to give some positive outcomes. However, since then, we've had quite a lot of researchers really trying to drill down to the key features that seem to make a difference. And there are some very clear patterns. This is where actually I was very lucky because this lady had imaging and I knew exactly what I was dealing with. This lady had a supraspinatus and infraspinatus tear, but her subscapularis and her teres minor were intact. The bottom line is, if your subscap or part of your subscap and your teres minor are intact, you've got a really good chance of doing well with conservative management, so with our rehabilitation. Now, remember, this lady isn't going to have surgery, and most of the patients included in those studies were irreparable, or in one, I think it was the Collins or Cavalier, they compared it with injection, which also seemed to have some effect, and actually doing some arthroscopic surgery and doing a biceps tenodesis. But the bottom line is, when we look at those patients who predictably do well, what a lot of these studies did is look at it as 5 tendons. So subscap, you've got the lower and upper part. You've then got your supraspinatus, your infraspinatus, and your teres minor. So almost look at that as 5 different tendons. Essentially, the people who do well are those who've got one part of subscap intact. So as long as they've got one part, they seem to be able to compensate, and with that teres minor. Patients who have a complete subscap tear do not do well. Similarly, patients who have a 3 tendon tear have a much less predictable outcome. So interestingly, it seems that our older patients with 2 tendon tears, particularly if it's supraspinatus and infraspinatus, and they've got significant pseudoparalysis, in terms of only 30 or 40 degrees elevation, those cohorts do really well. They get excellent elevation up to 160, an average of about 130 elevation, and abduction. But importantly, they don't get external rotation strength back. So that's really important when we're setting expectations. Now, if we looked at addressing all the things I talked to you about and putting that together as a program, would we have better outcomes? The bottom line is, guys, we don't know because we haven't done it yet. So when I look at the things and what I started with this lady, again, I could have got her in lying. Sometimes if patients are really struggling even to get elevation in lying, that's where I like to use the kinetic chain just to make life even easier. So you can get patients to do a bridge as they do that short to long lever elevation at 90, and sometimes just exaggerating the rest of the body is a really good way. Probably has some distractive element, but also if you imagine you exaggerate the rest of the body, you just make life easier for the shoulder, and there is some evidence to suggest it just helps improve local recruitment of which muscles you've got intact. So that can be a nice entry level strategy. Now this lady again wasn't terribly comfortable lying down. She, because of the treatment she'd had for a cancer and stuff, she was just much more comfortable upright. And if we think of the proprioceptive deficits these patients have, there's no doubt that sitting and standing are better positions to do that. So for me, I really like table slides. It's such a simple exercise. But if you think of those cortical changes, we can do cross midline, which will help get that cross hemisphere communication. We can get reaching for targets. We can vary the amount of load. We can even assist it with the other arm. Again, we can just put a TheraBand around her back to really start getting serratus, and it's very easy to change that range of movement. And then I'm just going to progress it according to how the patient is able. Now, ideally, we'd love to get onto the wall. Again, I quite get them on a slidey surface with a towel, with a loop of TheraBand, just to give them some sensory input. Again, they can use the kinetic chain. So if you like, looking at all the different ways I can unload that system. So when I look at the evidence about those different things, I do like to target the remnants of the cuff in terms of subscap. But again, if you think of those Cavalli, Collin and Agut papers, and actually another paper that's just been come out from Ann Kuhl's group, if you get patients to pull into extension, so imagine attaching a TheraBand to a door, getting them to step forward as they pull back into internal rotation and extension, that's a really nice subscap exercise, but also a scapular exercise as well, not into a provocative position. So there's really nice ways of doing it that can really respect the patient's pain. So the first time I sent this lady away home, she was doing a nice table slide. She was doing this step back in terms of her subscap and her scapula, and she was also doing external rotation, so only 3 exercises. Now this lady came back the next time and she was significantly better. Now guys, I told this lady it was going to take between 6 to 9 months, but the good news is she'd see a significant change by 3 months, because that's what the evidence says. It's absolutely clear. Patients can take up to 6 months. If they're 80 or older, it can take up to 9 months to get the optimal outcome. If they're 70 or under 80, then they might get there in 6 months, and they're less likely to improve after 6 months. So they kind of get their improvement a little bit quicker. But this lady seemed to get a really quick improvement. Now, remember, she's very motivated. She's got a treadmill at home. She goes out, she does stuff. But the other thing I talked to her about was just supporting, because it was her dominant hand, supporting it with her other arm when she did anything functional, just so, again, we're kind of tapping into those cortical things. Now, I know she's got 2 tendon tear on her scan, but it was phenomenal how quickly she compensated. And I've seen this a few times, and I'd love to think that I'd done something magic. But the bottom line is it was probably giving her confidence to move, changing her movement strategies, addressing some of her fears and getting her a bit more confident to move, but also some exercises, again, that allowed her to get very confident. Now, in terms of talking about this tonight, really some of the key messages that I wanted to talk about were, 1, being able to identify those patients that are likely to do well, and that's where imaging can be useful. If you haven't got imaging, remember, it can be very difficult to tell if somebody's truly weak. We have our lag signs, we have our cuff, just resistant testing. But remember, if they're painful and weak, it can be difficult to know if it's pain inhibition or you've got somebody who actually has got a tear. Now, interestingly, all these studies included groups that had mild trauma, so an extension of a previous degenerative tear, and those who had no history of trauma, but on average they'd all had symptoms for a long time. So again, the positive message is, even when they've had symptoms for a long time, if they're in those groups, that you can find somewhere where you can get some elevation. They've got part of subscap or teres minor intact, so you can find somewhere that they can create internal rotation force and external rotation force, then it would seem that they've got a really good chance of doing well with our interventions. But as ever, it's the patient setting them up with realistic expectations. And unlike this lady who did very well very quickly, again, the evidence is really clear that it can take up to 3 months for them to see a change in their function and their symptoms, up to 6 months to get the maximum improvement, unless they're in the older groups, and then it can take up to 9 months. And all those things just allow us as clinicians to be really confident, 1, to find out what we're dealing with, 2, to set realistic expectations, but also 3, to have lots of different options that are applicable according to the patient and their specific restrictions in terms of other health problems. If they've got chest issues and they can't lie down, these really simple exercises have a very good evidence base, and importantly, some papers to suggest that they are successful. But as ever for me, I really like to make things as sensory rich as possible, just make it as meaningful to the patient. And I think in this group particularly, it kind of makes sense in terms of targeting those cortical changes. It'll be exciting when Veronica Comboy does her later research looking at rescanning the brains of people who've had rehab and seeing whether we actually can affect those central changes. But also don't forget that very simple anterior deltoid program with a bit of external rotation and internal rotation thrown in does have successful outcomes in those patients who just have infraspinatus and supraspinatus involved. So we don't have to make it complicated. But I just think it's nice to have lots of options that are maybe more functional, more proprioceptive, and we can adapt according to the age and the physical ability of the patient in front of me. Now, the only other thing to say again is if I had somebody who wasn't quite as fit and healthy as this lady, who's obviously walking regularly, then it's also a great opportunity to just increase, if you like, their potential by targeting the rest of the body. We know there's a huge correlation with lower limb strength and all-cause mortality. So again, when patients have these injuries and you know it's going to be a bit of a long haul, it can be really useful just getting them to do sit to stand as part of their table slides so that we improve their lower quadrant strength as well. And of course, there's lots of other ways that we can address that. So guys, I hope I've given you a rundown of what's out there in terms of the evidence. I know the chats have been coming in and I'll have a look at those now. But I think the key thing really that I wanted to share with you is there have been some newer papers which suggest some alternatives to the anterior deltoid program. From my perspective, I think, again, I really like looking at the research that evaluates these patients and looks at those specific deficits to give us some more ideas for our exercises. And I think the bottom line is we've probably got even more potential. But I also think it's important to be realistic. And that's why the evidence is so helpful in identifying that if we have no subscap, then guys, actually, we have a zilch success rate when you look at the current literature. So I really hope that's giving you some tips and tricks about massive rotator cuff tears. Right, let's have a little look at the questions. What's your opinion on prolotherapy for the treatment of rotator cuff tears and lesions if a surgeon is not considering surgery? Essentially, Tim, as far as I'm aware, there's very little evidence for prolotherapy in terms of actual cuff tears. There's far more interest at the moment in biologics and PRP and things like that, because they're looking at actually promoting healing. Now, again, I think when you look at younger populations, when you've got a more metabolically active tissue, then essentially that's not an unreasonable thing to do, and there's a lot of research interest in that at the moment. But in this group with a really degenerative tear, I did a research assistance post way back when, I think 2005, if I remember rightly, could even be before that, but I did a 3-year post that was basically about patients having massive cuff tears repaired and reinforced with a pig patch. And what we saw is the experience of many surgeons since is that people just re-tear outside those patches. So really you can't defeat biology in a degenerative population with fatty infiltration, with retraction of the tear edges. And so actually what we're seeing now is a real move away from trying to repair these things. If patients don't do well with our conservative measures, then they may do a partial repair and an arthroscope just to give them some pain relief. They may do muscle transfers in a slightly younger cohort, but actually reverse total shoulder is also very popular. But what's interesting when we look at surgical groups, again, not having subscapular teres minor does make things more difficult even in the surgical groups. So I hope that answers that, Tim. Great question. Rachel, can you explain the step forward extended arm back? So if you look at Karen, great question. How does it help subscap? So we always think of subscap and just working it in terms of doing internal rotation. Now, as in arm supported by the side with a pillow and literally just doing TheraBand. Now, there's nothing wrong with that. However, if you look at Karen Jin's lovely research, the bottom line is that if you look at which part of the cuff's working hardest, when we go into extension, so if you imagine with my arms by my side, if I just lift back behind me, my subscap is the part of the cuff that works hardest. In flexion, it's the posterior cuff that works the hardest. So actually, extension is a really nice subscap exercise, but we also know it has good value for the scapula as well. So if I get her to attach a band to the door and then get her to step forward, I always like a bit of kinetic change just to make life easier for the shoulder. But again, probably distractive as well, but get her to step forwards and pull back and internally rotate as she extends. That's how I'm targeting subscap. So I hope that answers that question, but very much based on Karen Jin's lovely research. I've just seen Luke's question. I'll come back to that in Luke in a minute, but I might need a gin before I can answer that one. Dudson, do you think compensatory humeral head depressor activity has a role in rehab? I'm so glad you asked me that question because there's one thing I've forgotten to tell you. So remember, we talked about that loss of force couple, and remember in that Collins and Cavalier study, they talked about passive repositioning of the humeral head. Now, for me personally, I'm always wanting to do something that the patient can replicate at home. So I do quite like mobilizations with movement, but the patient doing it with TheraBand. So if you imagine I'd attach a fairly high resistance TheraBand to a door, get it over the front of the patient's shoulder, and then get them to actually, if you like, move into that as they do assisted elevation or external rotation, whatever exercise we're doing. So they almost get that kind of repositioning effect. Now, I'm under no illusions. I'm sure it has no biomechanical effect, but it's a really nice sensory cue. I think the other thing that's interesting about what you're saying, Dudson, again, if you look at some of the evidence in terms of that balance between deltoid, lats, some of the other things that can give an inferior or that humeral depressor effect, then again, when you look at some of these exercises working at 90, whether it's a table slide, a wall slide, or doing the supine, actually, as you load that up, you do start to get activity in those muscles as well. But again, I think if you look at the way that authors describe doing internal rotation in neutral with that support and a little bit of adduction, then that's actually targeting those humeral depressors as well. So I think it's a really good point, and I think that's some other things that we can add in based on that. So thank you for reminding me. I have to share with you, Luke's asked me, what do I think of Liverpool's home form? That's going to make me cry, so I probably think we need to move on from that. We're just wallowing in the glory of last year, and hopefully we'll be back on course very soon. Oh, lovely. It was amazing, Jo. Since registering for the shoulder course, I can't believe how easy to understand the concept and apply exercise in clinic. It's amazing. Oh, that's awesome. Thank you, Afsane. I'm sure I haven't pronounced your name right, but thank you very much for that. That's awesome. Oh, guys, some lovely comments. Luke, I'll let you off because it's nice to have you here. So, guys, all of you that have said hello, it's really lovely to have you here. It's very humbling that you turn out every Monday to hear some more shoulder geeking. As I say, Dudson, thanks for that question because it's important to take about the humeral head depressors. Certainly, some of the research that our unit have done, they've certainly looked at things like pec major, which again can have a humeral head depressor effect if it works in balance with some of the other muscles. So again, I think there's lots of potential to perhaps look at some other ways of achieving this, but I think it's interesting that the EMG studies, if we can trust them, suggest that actually that's probably something we're inadvertently addressing already. So, guys, thank you so much. Another 30 minutes. I can never stick to time. I'm already 2 minutes over. Thanks so much for joining us. I really hope you've taken some useful clinical tips away from that and how to set some realistic expectations and what to consider when we set out with these patients. I promise I'll post some links on the Clinical Edge Facebook page, links to those articles. But as ever, thanks so much for joining. Really hope you've enjoyed it and look forward to seeing you at our next Facebook Live. Bye for now.